Hello, my name is Dr. Susan O'Brien, and I'm the Ashbel Smith Professor in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. I'm often asked, what are the roles Sokal and Hansford risk calculations have in prognosis and treatment of CML? We do look at the risk category because we know that some of the early events that we fear, such as early transformation, which is probably the most feared one. In other words, a patient seems to be responding to therapy, but then they have a sudden transformation to blast crisis. Although that incidence is very low, we're only talking single-digit percentages, that's obviously not good when it happens because treating a patient now in blast crisis is obviously a lot more complicated with a lot poorer prognosis than a patient in chronic phase. So what we know is that patients who have high Sokal risk in particular, not so much intermediate, but particularly high, are the ones who are most likely to have this complication. Now, in the new NCCN guidelines, we have a 3-month evaluation point, irrespective of risk, to try and look at an early time point for potentially changing treatment in patients before that event could happen. Would it impact your choice of treatment up front? I think it might, in the sense that if you know that there's a higher risk for transformation on imatinib, which we know from the randomized trials. Again, small percentage, but higher. And you know that most of the transformation occurs in high-risk patients, probably those are the ones where most physicians are going to prefer to start with a second-generation TKI as opposed to imatinib, because of the fact that that's the high-risk population that you're worried about. The guidelines don't specify a specific treatment based on Sokal risk, but if you talk to most of the participants in the guidelines, they would tell you that probably if they had a high-risk patient, they would be more likely to begin with a second-generation TKI.